Welcome to the first of a series of slideshows that will explain exciting recent developments in stress theory that promise revolutionary advances in medicine and biology. The recently discovered mammalian stress mechanism enables the unified theory of medicine that was postulated by Selye more than 60 years ago. Selye's revolutionary theory has always promised a new era of health, longevity, prosperity, and freedom from the eternal scourge of disease and premature death. But until now, it was useless without a testable mechanism that explains how it works. The stress mechanism will surpass the significance of DNA because it will elevate medicine from an art based on experiment to a science founded on theory. It explains the nature of physiology, pharmacology, and disease, including cancer, adult respiratory distress syndrome, multi-organ failure syndrome, eclampsia, pneumonia, influenza, and asthma. It confers a simple, safe, comfortable treatments. It enables the alteration of anesthetic technique to optimize surgical safety, efficiency, and patient comfort. It confers control of epidemics. It provides immense opportunity for efficient and profitable pharmaceutical research. Its implications exceed the bounds of medicine. It explains how DNA genetic information is converted into structural development. It thereby provides the final missing cog in the machinery of life that confers a previously unanticipated unified theory of biology that explains the origin and nature of life, with implications hitherto confined to the realm of science fiction. At long last, the very secret of life may be at hand. This first slideshow will review the history of stress theory, and it will be followed by a series of brief presentations that explain the operation of the stress mechanism. I would like to dedicate these slideshows to Dr. Johannes Rodin, whose lectures on stress theory to more than 5,000 medical students ultimately inspired the discovery of the mammalian stress mechanism. Were it not for him, the stress mechanism would have remained undiscovered for years to come. Sadly, Dr. Rodin passed away in 2004, only a few years before his dream was fulfilled. He was a magnificent gentleman and scholar as well as a famous researcher, and he would have been gratified to see that his efforts were not in vain. May his memory endure. The story of stress theory exemplifies the pattern of scientific advance postulated by Thomas Kuhn in his famous book, The Structure of Scientific Revolutions. Kuhn described how major advances in scientific theory are separated by prolonged intervals of normal science, where researchers toil in the context of a prevailing paradigm. As fresh evidence accumulates, the shortcomings of the prevailing paradigm become increasingly obvious, and complex rationalizations become necessary. Eventually, a new theory replaces the exhausted paradigm, reinvigorates research, and makes the world look different. Kuhn observed that most important scientific advances are contributed by amateurs working outside the field, and that they are seldom embraced by experts for many years. Today, Selye is seldom mentioned, but his important ideas are misrepresented or forgotten. But within living memory, he was considered to be the most important medical theorist and researcher in the world. Shortly before the discovery of DNA, Selye hypothesized that a single mechanism explains physiology, pathology, and stress. He believed that the discovery of this mechanism would elevate medicine from an art based on experiment to a true science founded on theory, and revolutionize medical treatments and pharmaceutical development. Selye's ideas became known as stress theory, and his hypothetical mechanism became known as the stress mechanism. Soon after Selye proposed stress theory, the unprecedented discovery of DNA inspired excitement that is now difficult to perceive. Many believed that the secret of life was close, and they anticipated that Selye's mechanism works closely with DNA to convert genetic information into complex structures, whereupon DNA would resume quiescence while the stress mechanism remained active for the remainder of life to maintain and repair mature anatomical structures. These compelling ideas, which were never disproved, inspired an intense but fruitless and frustrating international search for the stress mechanism that lasted 30 years and consumed hundreds of research careers, thousands of tortured test animals, and millions of dollars. Stress researchers developed two important theories to explain the nature of Selye's mechanism. They knew that capillary surface area is greater than all other vessels combined, and that capillary turbulence, pressure, and flow are all minimal, so they postulated that a submicroscopic capillary gate mechanism regulates capillary flow. This became known as capillary gate theory. They postulated that a single mechanism orchestrates the orderly sequence of tissue repair. This became known as tissue repair theory. They also suspected that the vascular endothelium was the focus of stress mechanism activity because it insulates blood from extravascular tissues, and they suspected that the autonomic nervous system regulates stress mechanism activity. As we shall see, all these ideas anticipated various elements of the mammalian stress mechanism. In retrospect, the stress researchers resembled Jules Verne planning a trip to the moon before rockets were invented. The mammalian stress mechanism is more complex and counterintuitive than anyone anticipated. There were critical gaps in the information needed to describe the mechanism. Lasers and transistors had recently been discovered, but research technology remained primitive, so that the means to generate essential information often didn't yet exist. Computers were primitive, slow, and expensive. Software was crude. The internet and email didn't exist. Literature search and review was cumbersome and time-consuming, and statistics were seldom utilized to evaluate data. The details of blood enzyme activity, apoptosis, thrombin receptors, chemokines, and cytokines remained undiscovered. Turbulence remained the greatest mystery of physics and engineering. Stress researchers focused inordinate attention on the relationships of HPA axis hormones, immune activity, and stress, but the nature of these relationships remained unclear. Meanwhile, they came closer to success than they realized when they described the coagulation cascade in the early 1960s. Many suspected its role in tissue repair, but essential information remained lacking. In retrospect, the coagulation cascade can be recognized as the first crude description of the mammalian stress mechanism. The era of stress research produced significant scientific achievements, but the stress mechanism itself defied discovery. The capillary gate and tissue repair theories seemed incompatible, and a single mechanism that could explain both seemed impossible. Selye's theory was useless without a testable mechanism that explained how it worked, and there was no clue of any mechanism that could explain any aspect of Selye's theory. As a result, stress research was largely abandoned and nearly forgotten. Even recently, prominent professors have proclaimed that no single mechanism could possibly explain the multiple manifestations of stress, physiology, and pathology. However, such is not the case. Selye's theory was never disproved, and it remains the simplest and therefore the most promising hope for a theory of medicine. Another 30 years of fresh evidence from unrelated research was needed to enable its discovery. Selye's long-sought stress mechanism was belatedly discovered 60 years after its prediction and 30 years after it was abandoned and forgotten, after the recently discovered chimeric nature of factor VIII inspired an intensive 6-year review of published literature using advanced computer techniques to screen relevant abstracts on PubMed. Its description remains crude, but it is compatible with existing knowledge, and it is testable. It confirms all the predictions and expectations of the old stress researchers. It is analogous to the coagulation cascade that was developed during the era of stress research. It incorporates a capillary gate component that is analogous to the intrinsic pathway of the coagulation cascade and capillary gate theory. It incorporates a tissue repair component that is analogous to the extrinsic pathway of the coagulation cascade and tissue repair theory. It explains how stressful tissue disruption and alterations in autonomic balance affect the vascular endothelium and activate the mechanism. As Selye predicted, the stress mechanism enables advanced medical treatments and efficient pharmaceutical development. It crudely explains how DNA directs complex structural development and evolutionary adaptations to environmental circumstances. The old stress researchers would be gratified that their efforts paved the path to discovery, but they would be surprised to learn that Selye's mechanism exceeds the bounds of medicine and confers a comprehensive explanation of the nature and relationships of microbiology, botany, zoology, anatomy, parasitology, embryology, evolution, the Cambrian explosion, taxonomy, paleontology, ethology, and intelligence. Further clarification of the mechanism will eventually enable the interpretation of genomic data with presently inconceivable consequences. I hope you enjoyed this brief introduction to stress theory and that it will inspire you to watch the following series of brief presentations that will be essential to explain the rather complex and counterintuitive operation of Selye's mechanism. Hopefully, these will be understandable for determined laymen as well as medical professionals and researchers. The next slideshow will begin by introducing the mammalian stress mechanism and its three products and explaining their effects. More information and copies of published papers can be obtained via my website, www.stressmechanism.com. Thanks for listening. Welcome to the second of this series of slideshows that explain the mammalian stress mechanism that was postulated by Hans Selye. This slideshow will introduce the stress mechanism and its three products. The mammalian stress mechanism is the veritable elephant in the living room of medicine. I call it the MSM for short. It is the homeostatic, self-limiting physiological mechanism that continuously maintains and repairs tissues and regulates hemodynamic physiology in mammals. It optimizes internal cellular environment and maintains complex multicellular structures. It is essential for life. It is activated by combinations of tissue disruption and nervous sensation, and its hyperactivity causes the symptoms and manifestations of disease. Understanding its activity is pertinent to all medical specialties. One might regard this simplified diagram of the MSM as an updated version of the familiar coagulation cascade that incorporates fresh research information generated by unrelated research during the past 30 years since Selye's theory was abandoned. As Selye anticipated, the MSM is a single cohesive mechanism that simultaneously regulates tissue repair and hemodynamic physiology to optimize cellular circumstances and maintain structural integrity. However, it is easier to comprehend as two semi-independent subcomponents. The extravascular tissue repair component, shown in blue, corresponds to the extrinsic pathway of the coagulation cascade. The intravascular capillary gate component, shown in red, corresponds to the intrinsic pathway of the coagulation cascade. The tissue repair component governs factor 7 activity to regulate tissue repair in accord with tissue disruption, and the capillary gate component governs factor 8 activity to regulate hemodynamic physiology in accord with autonomic balance. The activity of each subcomponent exaggerates that of the other to produce positive feedback that quickly focuses the mechanism on the site of tissue damage and facilitates repair. The easiest way to introduce the MSM is by exploring its end products. These are thrombin, soluble fibrin, and insoluble fibrin. The enzymatic interaction of blood-borne hepatic factors 7, 8, 9, and 10 generates and regulates all three products. Depending on circumstances, each product produces a variety of symptoms and manifestations. This explains how the MSM produces a bewildering blizzard of fluctuating effects that have confused researchers in the past. We will return to this diagram to explain how the mechanism works. Fibrinogen, soluble fibrin, and insoluble fibrin are closely related and chemically similar, so that they were persistently confused with one another during the era of stress research. The liver continuously releases fibrinogen into flowing blood. It is a structurally complex protein molecule that exists in multiple forms. It is a precursor of soluble fibrin. It cannot escape the intact vasculature. It consists of alpha, beta, and gamma subunits that are connected by disulfide bonds. Thrombin disrupts the disulfide bonds and causes the alpha, beta, and gamma fibrinogen subunits to rearrange themselves into fibrillar, or that is, two-dimensional, strands of soluble fibrin that might be likened to strands of spaghetti. These strands of soluble fibrin can escape through thrombin-induced inflammatory gaps in capillary walls and enter damaged tissues, where they create a lattice or matrix of fibers that facilitates the cellular activities of tissue repair. I call soluble fibrin the universal protein of tissue repair. It is so ubiquitous as to escape notice. It appears in saliva and mother's milk. It is a substance of pulmonary exudates, nasal discharge, pus, scabs, peritoneal deposits that appear after surgery, and the mucus that enables everything from digestion to defecation to respiratory tract cleansing to sex. It becomes dangerous when it is produced in excessive quantities by MSM hyperactivity. It escapes from blood through inflamed capillary walls, invades tissues, and causes tissue edema and organ disruption. It floods the lungs with exudates that disrupt gas exchange in ARDS, pneumonia, asthma, and influenza. In multi-organ failure syndrome, it causes a mental disturbance, liver swelling, and acute renal failure accompanied by hyaline cast formation. In eclampsia, which is analogous to multi-organ failure syndrome, it coats the placenta, disrupts oxygen exchange, and suffocates the fetus. In disseminated intravascular coagulation, it coats the inner walls of arteries and causes characteristic rosette formations by attaching to clumps of defective insoluble fibrin clots. In tuberculosis, soluble fibrin deposits form caseating lesions that frustrate antibiotic treatment. Soluble fibrin promotes collagen production, causing pulmonary fibrosis in the aftermath of lung disease, and peritoneal adhesions after abdominal surgery. I call insoluble fibrin the universal polymer of hemostasis. Nervous activity accelerates factor VIII activity that converts two-dimensional soluble fibrin to three-dimensional insoluble fibrin monomers that spontaneously polymerize into strands that reduce capillary flow, increase blood viscosity and coagulability, impair cardiac efficiency, predispose to infarction, and entangle platelets and red cells into clots. Unlike a fibrin, insoluble fibrin cannot escape the intact vascular system, and it is susceptible to anticoagulants. The insoluble fibrin molecule incorporates plasminogen, which spontaneously disintegrates into plasmin that disintegrates the clot unless it is continuously stabilized by thrombin. Thrombin is the most important of the three MSM products. I call thrombin the universal enzyme of extracellular enzyme transduction. As gasoline energizes automobile motion, ATP energizes cells and extracellular enzymes. As automobile engines convert gasoline into motion, thrombin converts ATP into cell and extracellular enzyme activity. As the throttle regulates engine power output, parathyroid glands regulate extracellular calcium within a narrow range to optimize thrombin activity, which explains why they are vital to life. Protease-activated receptors, or PAR, were unknown in the era of stress research. PAR are thrombin receptors. All cells have PAR on their surface. At least 4 types of PAR have been discovered thus far. These are known as PAR1, PAR2, PAR3, and PAR4. Individual cell types are characterized by PAR types and numbers that determine how the cells react to thrombin elevations. Thrombin, ATP, and calcium are essential for extracellular enzyme activities, including the complement cascade, the coagulation cascade, and gelsolin, which digests actin. This prevents actin from becoming entangled with insoluble fibrin and disrupting clot formation. Thrombin energizes the conversion of fibrinogen to soluble fibrin, which facilitates tissue repair, and the subsequent conversion of soluble fibrin to insoluble fibrin, which enables hemostasis and the regulation of blood flow in tissues and organs. Thrombin also stabilizes insoluble fibrin by energizing thrombin-activated fibrinolysis inhibitor. This more complete MSM diagram shows thrombin pathways in orange. The MSM continuously generates small amounts of thrombin in all tissues to energize tissue maintenance. In the event of injury, it accelerates thrombin generation to energize coagulation. It then regulates elevated thrombin levels within a narrow range to optimize tissue repair and prevent cellular hyperactivity that causes malignancy. As tissue repair nears completion, it reduces thrombin generation to maintenance levels. The resulting starvation induces apoptosis and clot disintegration, which facilitates resolution of the repair process. That is enough castor oil for one slideshow. The next slideshow will explain how the elegant enzymatic interaction of factors 7, 8, 9, and 10 generates and regulates thrombin, soluble fibrin, and insoluble fibrin. Thanks for listening. Welcome to the third of this series of slideshows that explain the mammalian stress mechanism that was postulated by Hans Selye. This presentation will review the relevant properties of the coagulation cascade enzymes and cofactors that generate thrombin, soluble fibrin, and insoluble fibrin. During the era of stress research, relatively little was known about the individual characteristics of coagulation cascade enzymes, including thrombin, tissue factor, and factors 7, 8, 9, and 10, and 13. All these enzymes and substances were assumed to be exclusively involved with blood coagulation. And even now, their role in tissue repair remains unrecognized. In particular, the universal requirement for thrombin to energize repair cell activities as well as extracellular enzymes has somehow escaped notice. Though many details remain unclear, fresh information from unrelated research accumulated since stress research was abandoned more than 30 years ago has enabled this simplified diagram of Selye's mechanism that shows how the elegant enzymatic interaction of factors 7, 8, 9, and 10 generates thrombin, soluble fibrin, and insoluble fibrin to enable both tissue repair and hemodynamic physiology. Factors 7, 8C, 9, and 10 are all produced by the liver and released continuously into the blood. Factors 9 and 10 have long half-lives so that their blood levels do not fluctuate. Factors 7 and 8C are extremely labile and must be stabilized respectively by tissue factor and von Willebrand factor in order to exert their enzymatic effects. Thus, fluctuating exposure to tissue factor to factor 7 and von Willebrand factor to factor 8C alters the interaction to govern the generation of thrombin, soluble fibrin, and insoluble fibrin. Hemostasis is optional, but tissue repair is essential. Coagulation cascade enzymes generate thrombin to energize tissue maintenance and repair, and clot formation is merely the first step in an orderly sequence of repair activity that restores tissue structures and function. Small amounts of thrombin generated by factor 7 is essential for the activities of factors 8, 9, and 10, which generate additional quantities of thrombin that energize all MSM activities. Tissue factor is a sausage-shaped protein that is tethered to the surface of the cell so that the external portion interacts with blood enzymes. The tethered segment enables cell signaling. Tissue factor initiates factor 7 activity that generates thrombin. All cells appear to have the ability to generate tissue factor, but tissue concentrations of tissue factor reflect hemostasis requirements. Brain, lung, perivascular fibroblasts, peripheral nerves, autonomic ganglia, placenta, and the muscularis mucosa of the esophagus are all rich in tissue factor. The epithelium of skin, mucosa, cardiac muscle, and glomeruli have moderate levels of tissue factor. Little tissue factor is found in skeletal muscle, smooth muscle, excretory ducts, tunica intima, and tunica media. Tissues with high concentrations of tissue factor are targets for stress-related disease manifestations in adult respiratory distress syndrome, multi-organ failure syndrome, eclampsia, and malignancy. All of these illnesses are closely related and could be managed more effectively if their nature were understood. This picture portrays tissue factor binding to factor 7. This stabilizes factor 7 and enables it to generate small amounts of thrombin that energize the activities of factors 8, 9, and 10. Factor 7 thus functions as a trigger for this enzymatic interaction. The complex of tissue factor and factor 7 binds to factor 10. This amplifies thrombin generation and induces factor 10 proliferation. The interaction of tissue factor with factors 7 and 10 is the engine of embryological development and tissue repair, so that defects in any of these three factors are usually lethal. Likewise, anticoagulants such as warfarin and fondaparinux that interfere with this interaction will disrupt embryological development and wound healing, as well as clot formation. This explains why they cannot be used during pregnancy. However, treatment with these anticoagulants reduces malignancy risk and enhances the chance of cancer cure. The liver continuously produces factor 8C and releases it into flowing blood. 8C accelerates thrombin generation to convert factor 10 to factor 13. The 8C enzyme is extremely labile and it cannot exert its enzymatic effects unless it is stabilized by von Willebrand factor. Defects in the 8C enzyme cause true hemophilia, which is a severe sex-linked clotting diathesis that mostly afflicts males. The vascular endothelium releases von Willebrand factor into blood in accord with sympathetic nervous system tone and activity. It binds to enzymatic factor 8C to form the chimeric factor 8 molecular complex so that the two molecules circulate together and exert their effects in concert. Von Willebrand factor has no enzymatic properties of its own, but it stabilizes factor 8C and enables factor 8 activity. Defects in von Willebrand factor cause von Willebrand clotting diathesis, which is usually mild, but in some cases it is clinically indistinguishable from true hemophilia. The severity of the clotting diathesis fluctuates in accord with sympathetic tone and activity. Von Willebrand factor also maintains capillary structure, so that von Willebrand factor defects also cause angiodysplasia. Bee stings sometimes trigger sudden complement cascade activity that rapidly attacks and destroys von Willebrand factor, causing anaphylactic shock. This causes hypotension, but cardiac output and tissue perfusion are little affected. It also causes tissue edema that can cause lethal airway obstruction. The treatment of choice is epinephrine, which releases fresh von Willebrand factor from the vascular endothelium. All these phenomena will be discussed in greater detail in later slideshows. Factor VIII is a gigantic chimeric molecule consisting of von Willebrand factor and the vascular endothelium, and from the vascular endothelium, and 8C from the liver that bind together and exert their effects in concert. The rare chimeric nature of factor VIII was unsuspected during the era of stress research. It inspired an extensive review of published literature that enabled the discovery of Selye's mechanism. The unique characteristics of factor VIII functioned as a Rosetta Stone that deciphered stress mechanism function. Both the 8C enzyme and von Willebrand factor are gigantic molecules, and the factor VIII molecular complex is so large that it cannot penetrate the clot of its own making. This limits clot formation to the immediate area of tissue damage. Factor IX is a cofactor of factor VIII. It amplifies factor VIII activity, but it does not affect the other enzymes. Sex-linked defects in factor IX cause a mild coagulopathy called Christmas disease that has little effect on tissue repair or embryological development. Factor IX amplifies factor VIII activity, and factor VIII interacts with the complex of factors 7, 8, factor 7, factor 10, and tissue factor to generate factor 13, which converts soluble fibrin to insoluble fibrin. Defects in factors 7, 9, and 13, or excuse me, 8, 9, and 13 are not lethal because they do not disrupt embryological development and tissue repair. Likewise, anticoagulants such as heparin and Plavix that inhibit factor VIII can be used safely during pregnancy because they do not disrupt embryological development. Factor 13 adds crosslinks of fibronectin and plasminogen to soluble fibrin to generate insoluble fibrin monomers that polymerize into strands of insoluble fibrin. Defects of factor 13 are rare and usually mild. It's time for a pause. The next presentation will discuss the vascular endothelium. Thanks for listening. Welcome to Part 4 of this series of presentations that describe the mammalian stress mechanism postulated by Hans Selye. This slideshow will present pertinent attributes of the vascular endothelium, which is the focus of all stress mechanism activity. The vascular endothelium is a diaphanous layer of cells, one cell thick, that lines the inner surface of all arteries, arterioles, veins, and venules. It insulates flowing blood from extravascular tissues. It produces several stress mechanism substances and enzymes, including von Willebrand factor, tissue plasminogen activator, nitric oxide, fibronectin, vitronectin, thrombin-activated fibrinolysis inhibitor, protein C, and stoichiometric AT3. The vascular endothelium is the sole constituent of capillary walls, which are only one cell thick. Capillary surface area is vastly greater than that of all other vessels combined. Capillary pressure, flow, and turbulence are negligible compared to larger vessels. Capillaries have no muscular elements that enable vasoconstriction or capillary hemostasis. The green cells on the left portray healthy vascular endothelium that insulates flowing blood from extravascular tissues. The gray cells in the center represent gap formation between endothelial cells induced by thrombin, radiation, and toxic chemicals, which increases contact between blood and extravascular tissues. The flesh-colored cells on the right portray disruption of the vascular endothelium by trauma and surgery, which directly exposes blood enzymes to tissue factor. Factor VII in flowing blood slowly but continuously penetrates the healthy vascular endothelium to enter extravascular tissues, where it is activated by tissue factor. In the absence of factor X, it generates small amounts of thrombin that energize tissue maintenance. Tissue factor slowly leaks into flowing blood, where it activates factor VII and generates small amounts of thrombin that activate factors 8, 9, and 10. The vascular endothelium produces and releases stoichiometric AT3, fluctuating protein C, and tissue factor pathway inhibitor that continuously quench and control factor VII activity. This normally controls thrombin generation and flowing blood within a narrow range, but these inhibiting mechanisms can be overwhelmed by stress-induced enzyme hyperactivity and positive feedback that produces the manifestations of disease. The gigantic size of factor VIII prevents it from penetrating the intact vascular endothelium or inflammatory gaps in capillary walls, or even the viscoelastic clot of its own making, so that it becomes fully active only when the vascular endothelium is completely disrupted by trauma or surgery. This explains why radiation, toxic chemicals, and sepsis do not induce clot formation. Factor IX amplifies factor VIII activity, but does not interact with the other blood enzymes, so its ability to penetrate the vascular endothelium is irrelevant. Factor X cannot penetrate the intact vascular endothelium, but it is small enough to pass through inflammatory gaps in capillary walls induced by sepsis, toxic chemicals, and radiation. It also penetrates the viscoelastic clot so that it interacts with factor VII and tissue factor in damaged tissues and elevates thrombin generation to levels that sustain tissue repair. This interaction of factors 7 and 10 with tissue factor is the engine of tissue repair and embryological development. Radiation, toxic chemicals, and sepsis increase the permeability of the vascular endothelium and allow factor X as well as factor VII to penetrate the capillary walls, which elevates thrombin generation to levels that sustain tissue repair. Factor VIII cannot penetrate the intact vascular endothelium on account of its gigantic size, which explains why clot formation is absent in these conditions. Radiation, toxic chemicals, and sepsis also increase the leakage of tissue factor into flowing blood, which exaggerates thrombin generation in flowing blood, causing harmful systemic inflammatory effects and positive feedback. Surgery disrupts the vascular endothelium and releases tissue factor into flowing blood, which abnormally exaggerates factor VII activity, overwhelms inhibitory mechanisms, and induces positive feedback that reaches peak intensity 48 hours later. This explains why the manifestations of surgical stress occur distant from the time and location of surgery, and why they are related to the degree and duration of surgical tissue disruption. Major trauma causes similar consequences. Tissue disruption directly and simultaneously exposes tissue factor to all 4 blood enzymes. Tissue factor activates factor VII, to generate small amounts of thrombin that initiates the interaction. Factor 10 elevates thrombin generation to replicate itself. Factor 8 further elevates thrombin generation to energize its conversion of factor 10 to factor 13 to generate insoluble fibrin. And factor 9 exaggerates factor 8 activity. This powerful interaction enables coagulation that is limited to the area of tissue disruption because factor 8 cannot penetrate the viscoelastic clot of its own making. The viscoelastic clot stems blood loss, but its more important function is to regulate tissue repair. This will be discussed in detail in the next slideshow. The vascular endothelium is specialized to optimize function in different organs and tissues. The blood-brain barrier consists of endothelial cells with tight junctions that limit permeability. Compared to brain tissue, the endothelial cells of renal and hepatic tissues have loose junctions that optimize the function of these organs. The vascular endothelium has both sympathetic and parasympathetic innervation in vital organs such as brain, lung, and bowel. Electronic signals also travel from cell to cell in the vascular endothelium, so that direct autonomic innervation is not necessary to govern each and every cell. Sympathetic nervous system stimulation causes the vascular endothelium to release von Willebrand factor into flowing blood, which exaggerates factor 8 activity and increases insoluble fibrin generation in capillaries and flowing blood. This has widespread effects. Insoluble fibrin increases blood viscosity and inhibits tissue perfusion. The intense sympathetic nervous system stimulation activates capillary hemostasis and causes infarction. Parasympathetic nervous system activity induces the release of nitric oxide from the vascular endothelium. Nitric oxide binds to calcium, inhibits thrombin, accelerates insoluble fibrin disintegration, and promotes tissue perfusion and organ function. Epinephrine and insulin are hormones that extend autonomic effects to peripheral tissues, such as skeletal muscle, where direct autonomic innervation is lacking. Sympathetic nervous system activity stimulates the release of epinephrine from the adrenal glands, which releases von Willebrand factor from the vascular endothelium into flowing blood and increases insoluble fibrin generation. Parasympathetic nervous system stimulation releases insulin from the pancreas, which induces the release of nitric oxide from the vascular endothelium and disintegrates insoluble fibrin. Brain astrocytes release both tissue plasminogen activator and nitric oxide that disintegrate insoluble fibrin and preserve brain perfusion. Their activity prevents brain infarction when large amounts of epinephrine are administered during cardiopulmonary resuscitation. That is enough for one slideshow. The next slideshow will explain the tissue repair mechanism. Welcome to part 5 of this series of presentations that describe the mammalian stress mechanism postulated by Hans Selye. This slideshow will discuss the tissue repair component of Selye's mechanism. Selye's stress mechanism is a single cohesive mechanism, but it is easier to comprehend in terms of two semi-independent subcomponents called the capillary gate component and the tissue repair component. The tissue repair component, which is illustrated in blue in this simplified diagram, regulates factor 7 activity to govern the location, degree, and duration of thrombin generation in extravascular tissues in accord with the degree, duration, and location of stressful tissue disruption to enable tissue repair. This sounds simple, but the devil is in the details. The previous slideshow explained how the vascular endothelium alters the interaction of blood enzymes with tissue factor in accord with different types of stress. This presentation will add more details that explain the nature of tissue repair. This will be followed by slideshows that explain the capillary gate mechanism. Thrombin energizes all the cell and extracellular enzyme activities involved in tissue repair, including platelet activation, hemostasis, inflammation, chemotaxis, mitosis, metabolism, hypertrophy, angiogenesis, immune activity, and replacement tissue production. The tissue repair component continuously generates small amounts of thrombin in all tissues to energize the slow collagen turnover and cell replacement necessary for tissue maintenance. It generates high levels of thrombin to energize hemostasis in the immediate aftermath of injury. It then maintains moderate thrombin elevations within a narrow range to optimize tissue repair. As tissue repair nears completion, it returns thrombin generation to maintenance levels. Tissue repair proceeds in a predictable sequence of bleeding, hemostasis, inflammation, chemotaxis, cell proliferation, cell differentiation, and remodeling. Each of these phases merges smoothly into the next, which implies the presence of a cohesive process controlled by a single mechanism, but no such mechanism has previously been described. The first event in tissue repair is hemostasis that stems blood loss and restores the barrier between flowing blood and extravascular tissues. Coagulation begins with the formation of a white clot consisting of activated platelets. Note the rich layer of tissue factor in the arterial wall outside the basement membrane and beneath the vascular endothelium. Tissue damage immediately exposes this tissue factor to blood enzymes and initiates the generation of thrombin, soluble fibrin, and insoluble fibrin in the damaged tissues. Simultaneously, systolic blood flow dynamics force platelets into the damaged tissues. Thrombin attracts the platelets via chemotaxis and activates them, causing them to change shape and release thromboxane that induces vasoconstriction in surrounding venules and arterioles, which reduces blood flow in the injured tissues and facilitates hemostasis. Propagating strands of insoluble fibrin bind the platelets into a white clot that temporarily restores the barrier between flowing blood and extravascular tissues and stems blood loss. Factor VIII plays a key role in hemostasis. It accelerates thrombin generation to produce insoluble fibrin in the immediate vicinity of tissue damage to enable clot formation. The gigantic size of factor VIII prevents it from penetrating the clot of its own making, which explains why coagulation is limited to the immediate vicinity of tissue damage. Rising levels of insoluble fibrin bind red cells into a more permanent red clot that replaces the white clot and substitutes for the damaged vascular endothelium. The red clot stems blood loss, but its more important function is to regulate thrombin generation to optimize tissue repair. Like the vascular endothelium, the viscoelastic red clot is selectively permeable. It allows the penetration of factors 7 and 10, which interact with tissue factor in the damaged tissues and generate thrombin that energizes repair cell activity. Rising thrombin levels activate thrombin-activated fibrinolysis inhibitor, or TAFI, which strengthens the clot, reduces its permeability, and decreases thrombin generation. Declining thrombin levels reduce the activity of TAFI, which increases the permeability of the clot and increases thrombin generation. The clot thus regulates thrombin generation in the damaged tissues within a narrow range that optimizes cellular tissue repair activities and prevents excessive thrombin levels that cause malignant repair cell hyperactivity. Inflammation follows coagulation in the tissue repair sequence. Rising thrombin levels in the damaged tissues energize the release of cellular hormones including chemokines, cytokines, caspases, prostaglandins, and bradykinin that dissolve the basement membrane that holds cells in tight formation and loosens cell connections. The rising thrombin levels also activate gap formation in capillary walls that allow soluble fibrin, blood enzymes, and plasma to penetrate into adjacent tissues, causing tissue edema. Soluble fibrin deposits form a matrix or lattice structure in the damaged tissues that facilitates cellular repair activities. The elevated thrombin levels cause increased cellular metabolic activity, which generates heat and elevates tissue temperature, and cell hormones promote perfusion. These activities explain the inflammation syndrome, which the ancient Greeks classically described as a syndrome consisting of tumor or swelling, rubor or redness, dolor or pain, calor or heat, and functiolesa or loss of function. These seemingly unrelated manifestations of tissue repair occur in concert due to thrombin elevations. The next event in the tissue repair sequence is chemotaxis. Thrombin-seeking repair cells in undamaged adjacent tissues move between the loosened cells in inflamed tissues to enter damaged tissues, where thrombin energizes their repair activities. The next phase of tissue repair is proliferation, where the arriving repair cells begin thrombin-energized repair activity. Fibroblasts multiply and generate collagen to produce granulation tissues that fills empty spaces. Immune cells phagocytize debris and bacteria and produce immune proteins to prevent infection. Myoblasts produce muscle, and osteoblasts produce bone to replace damaged tissues. Angiogenesis, or capillary formation by endothelial cells, perfuses the proliferating repair tissues. The cells release chemokines, cytokines, caspases, prostaglandins, and other cellular hormones to communicate with one another to coordinate their repair activities. The final phase of tissue repair is remodeling. As the vascular endothelium proliferates and restores the barrier between flowing blood and the damaged tissues, thrombin levels gradually decline. This progressively reduces repair activity until thrombin levels fall below a critical threshold, whereupon the clot disintegrates and disappears, and repair cells begin to undergo apoptosis that shrinks the healing tissues and draws wound edges together to complete the repair process. Thrombin generation returns to maintenance levels, but the remodeling process continues for the remainder of life, and the damaged tissues never completely return to normal. The previous slideshow explained how the vascular endothelium governs contact between blood enzymes and tissue factor in accord with the type, location, and duration and degree of stressful forces. Another variable that affects tissue repair component activity is the concentration of tissue factor. Organs that are rich in tissue factor, such as the brain, lung, and placenta, are hypersensitive to systemic thrombin elevations caused by surgery, sepsis, trauma, and other stresses. This explains the nature of ARDS, MOFS, DIC, eclampsia, malignancy, and the surgical stress syndrome. The brain is characterized by the highest metabolic requirements of all tissues. Brain tissue is accordingly endowed with astrocytes that produce TPA, or tissue plasminogen activator, that disintegrates insoluble fibrin to protect perfusion. As a result, brain tissue is notoriously vulnerable to hemorrhage. This bleeding tendency is partially offset by high levels of tissue factor, but this makes the brain a target organ for stress. Systemic thrombin elevations induced by surgery, sepsis, and trauma activate inflammatory gaps in brain endothelium that undermines the blood-brain barrier and allows soluble fibrin to invade brain tissue and disrupt brain function. This explains why mental dysfunction is a prominent consequence of sepsis, surgery, and trauma. Head trauma releases tissue factor into systemic circulation, causing harmful systemic factor VII activation that exaggerates morbidity and mortality. The elevated tissue factor level also explains why brain is a target organ for both primary and secondary malignancy. High tissue factor level minimizes bleeding in delicate lung tissue, but it exaggerates the sensitivity of lung tissue to stress. Inhaled particulate antigens, such as pollen, deposit on the inner walls of airways and provoke soluble fibrin production in the form of mucus exudates that reduce the diameter of airway passages and cause asthma. The problem manifests mostly in young children with small airway passages and is exaggerated during exhalation when airway diameter is further reduced. Bacteria and viruses provoke soluble fibrin production that floods pulmonary alveoli with exudates that disrupt gas exchange, causing pneumonia and influenza. Systemic thrombin elevations due to surgery, trauma, sepsis, blood transfusion, and cardiopulmonary bypass pump exposure cause harmful inflammatory effects in lung tissue that manifests as atelectasis, ARDS, or adult respiratory distress syndrome, transfusion-related lung injury, or TRALI, and systemic inflammatory response syndrome, or SIRS. All these phenomena have different names because they occur under different circumstances, but they are all essentially early manifestations of multi-organ failure syndrome, or MOFS. All these have, like the brain, lung tissue exhibits exaggerated vulnerability to both primary and secondary forms of malignancy. Pregnancy is a stressful condition that exaggerates factor VIII activity. The placenta is rich in tissue factor, which offsets bleeding, but exaggerates the risk of malignant mole and choriocarcinoma. As pregnancy progresses, amniotic fluid becomes polluted with meconium that is rich in tissue factor. These stressful factors exaggerate the risk of diabetes, hypertension, and eclampsia, which is essentially identical to multi-organ failure syndrome. The direct entry of amniotic fluid into systemic circulation sometimes provokes systemic factor VII activation, which not only causes acute eclampsia, but also consumes fibrinogen and fibronectin, which paralyzes hemostasis and causes disseminated intravascular coagulation. These pathologies cannot be fully appreciated without an understanding of the capillary gate component operation, which will be the subject of subsequent slideshows. Malignancy is confusing because it is a systemic disease with local manifestations. It will one day be regarded as the opposite of apoptosis. It is caused by chronic environmental stress that induces occult stress mechanism hyperactivity that persistently elevates systemic thrombin levels. This increases blood viscosity and coagulability and induces occult systemic inflammatory effects that promote cell proliferation that disrupts adjacent tissues, releases tissue factor, and stimulates nociception that further exaggerates thrombin generation. Such a vicious cycle becomes malignant when it becomes self-sustaining. Cancer cells are essentially identical to normal tissue repair cells engaged in the peak phase of tissue repair, which explains why cancer is often difficult to diagnose. Cancer occurs primarily in organs that are rich in tissue factor, such as brain, lung, and placenta. The systemic thrombin elevation explains why seemingly unrelated types of cancer appear in different locations. Cancer seldom kills by directly invading vital organs or causing lethal hemorrhage. Instead, most victims succumb to the effects of elevated blood viscosity and coagulability, such as infarction, pulmonary embolus, and organ dysfunction. Surgery, chemotherapy, and radiation therapy are misguided and counterproductive treatment strategies because they exaggerate stress mechanism hyperactivity. A better approach would be treatments that inhibit thrombin generation and induce apoptosis. In theory, cancer could be cured safely and comfortably within 24 hours by using such treatments. It is time for another break. The next slideshow will present the shortcomings of conventional hemodynamic physiology as a prelude to introducing the capillary gate component. Welcome to part 6 of this series of slideshows that describes the mammalian stress mechanism that was predicted by Hans Selye. This presentation will discuss the shortcomings of conventional hemodynamic theory as a prelude to introducing the capillary gate component of Selye's mechanism. Conventional theory presumes that autonomic balance governs combinations of cardiac power and muscular vasoconstriction to regulate cardiac output, blood pressure, tissue perfusion, and athletic performance, so that exercise conditioning causes the heart to grow bigger and stronger, and blood pressure is directly related to cardiac output and tissue perfusion. However, the idea that cardiac work is opposed by vasoconstriction implies that hemodynamic physiology is inherently inefficient. Essential hypertension, which increases cardiac work, causes progressive cardiac damage that ultimately results in congestive heart failure. Simple observations suggest that cardiac efficiency rivals electrical superconductivity. The human heart consumes less energy than a 40-watt light bulb. It can increase its output more than tenfold during intense exercise despite negligible changes in size or weight. In trained athletes, blood pressure remains normal during exercise and abnormally low at rest. Blood pressure normally declines well below awake levels during healthy sleep. Most mammalian hearts weigh less than 1% of total body weight, and they cannot pump blood more than a short distance in height, which explains why perfusion-dependent mammalian brains are located close to the heart and only a small distance above it. The giraffe requires a disproportionately gigantic heart. Anesthetized patients suffer serious risk of ischemic brain damage if they are placed in a sitting position. Conventional theory cannot explain atherosclerosis, which appears first at bifurcations and greater curvatures of large arteries close to the heart, but rarely afflicts small arteries and arterioles located distant from the heart. It is accelerated by age, sedentary lifestyle, diabetes, hypertension, chronic disease, emotional stress, and both hyperthyroid and hypothyroid metabolism. It is retarded by exercise, moderate wine consumption, anticoagulants, coagulopathies, and Down syndrome. Brain-damaged, bedridden patients often survive for years without developing atherosclerosis. Anemia inhibits both atherosclerosis and coagulation, while polycythemia accelerates atherosclerosis and exaggerates blood coagulability. Efforts to explain these confusing observations in terms of lipoprotein effects or pipe flow dynamics have proved futile. Hemoglobin encapsulation distinguishes vertebrates from invertebrates, but its purpose remains unclear. It does not enhance oxygen delivery, and mammalian red cell mass is far greater than necessary for effective oxygen transport. Furthermore, vertebrate classes are characterized by unique blood cell morphology. Mammals evolved directly from reptiles, but reptilian red cells are large, elliptical, and nucleated, whereas mammalian red cells are tiny, biconcave, and enucleated. Mammalian red cells are so closely similar among species that only an expert can discern the difference. The nature of blood pressure and Korotkov sounds remains unclear. Conventional theory assumes that blood pressure is directly related to cardiac cardiac contractility. Were this true, then the pulse would appear simultaneously and equally throughout the arterial tree with the onset of each ventricular contraction and promptly disappear when the ventricle relaxes, for blood, like water, is incompressible. Instead, the pulse appears as a turbulent wave during diastole when the heart muscle is in a state of relaxation, and blood pressure measures higher in small distal arteries than in large proximal arteries. The turbulent wave moves rapidly from the heart to distant parts of the arterial tree and generates lateral forces that are measured as blood pressure. Red cell mass, temperature, and arterial bifurcations all affect the turbulent wave. Regardless of how it is measured, blood pressure does not reliably correlate with cardiac output and tissue perfusion, and blood pressure measurements are similar among mammalian species. Conventional theory cannot explain how the left ventricular assist pump produces effective cardiac output despite the absence of blood pressure or pulse. The Hagen-Poiseuille equation is the classical description of the relationship of flow and pressure in pipes and arteries. Unfortunately, it is based on the false assumption that fluid flow in pipes is so-called laminar flow that is free of turbulence and flow friction. A common example of turbulent flow friction in water pipes occurs when water faucets in old houses are opened suddenly, so that water flow accelerates rapidly, causing severe vibration that is accompanied by sharp reductions in water flow and the appearance of debris that is dislodged from the inner surface of the pipes. The Hagen-Poiseuille equation cannot explain this phenomenon, and it is accurate only at extremely low flow rates. These examples should illustrate the need for improved physiology theory. The next slideshow will introduce the capillary gate component, which explains hemodynamic physiology and complements the activity of the tissue repair component. Thanks for listening. Welcome to part 7 of this series of slideshows that describe the mammalian stress mechanism that was predicted by Hans Selye. This presentation will introduce the capillary gate component that regulates hemodynamic physiology. This is my favorite part of Selye's mechanism because it is so counterintuitive. The capillary gate component generates and disintegrates insoluble fibrin in capillaries and flowing blood in accord with autonomic balance. It regulates blood viscosity, blood coagulability, cardiac output, blood pressure, pulse rate, tissue perfusion, and organ function. It simultaneously governs a submicroscopic capillary gate mechanism that regulates flow resistance in capillaries and a turbulence mechanism that regulates flow resistance in arteries and arterioles. The capillary gate component consists of the autonomic nervous system, the vascular endothelium, von Willebrand factor, nitric oxide, and the enzymatic interaction of factors 7, 8C, 9, 10, and 13. Factor 8 plays a pivotal role in capillary gate component function because it links nervous activity to blood enzymes. It is an extremely unusual chimeric combination of two gigantic molecules that are produced by different tissues at different locations under separate genetic control. These bind together in blood and exert their effects in concert. Factor 8C is an enzyme that is continuously released from the liver. Von Willebrand factor is released by the vascular endothelium in accord with sympathetic nervous system tone and activity, but it has no enzymatic activity of its own. However, the 8C enzyme is extremely labile and cannot exert its enzymatic activity unless it is stabilized by von Willebrand factor. As a result, the enzymatic activity of factor 8 fluctuates in accord with sympathetic nervous system tone and activity. Defects in 8C cause hemophilia, which is a sex-linked coagulation disorder that mostly afflicts males and is continuously severe. Defects in von Willebrand factor cause von Willebrand's disease, which is a coagulopathy that afflicts males and females equally and fluctuates in severity in accord with sympathetic tone and activity. The capillary gate closes when stressful stimuli increase sympathetic nervous system activity that stimulates the vascular endothelium to release von Willebrand factor. Von Willebrand factor stabilizes factor 8C, which increases factor 8 activity. Factor 8 accelerates thrombin generation to energize its conversions of factor 10 to factor 13. Factor 13 adds crosslinks of plasminogen and fibronectin to soluble fibrin to generate insoluble fibrin in capillaries and flowing blood. Thrombin also stabilizes insoluble fibrin via thrombin-activated fibrinolysis inhibitor, commonly called TAFI. So long as thrombin remains elevated, the insoluble fibrin molecule remains stable. Insoluble fibrin consists of strands of soluble fibrin that are connected together by crosslinks of fibronectin and plasminogen to form a complex mesh structure that is illustrated by the figure on the left. It polymerizes into strands that entangle red cells into clots, as illustrated by the picture on the right. The plasminogen crosslinks in the insoluble fibrin molecule are unstable, and they spontaneously degenerate into plasmin that attacks the insoluble fibrin lattice structure and dismembers it into fibrin split products. As a result, the insoluble fibrin molecule is inherently unstable, and it spontaneously disintegrates into fibrin split products unless it is continuously stabilized by thrombin via thrombin-activated fibrinolysis inhibitor. So thrombin energizes both the degeneration and the stabilization of insoluble fibrin, and thrombin opposes the effects of plasmin. Nitric oxide is a gaseous molecule that is produced and released by the vascular endothelium. It binds avidly to ionized calcium and inhibits thrombin. Parasympathetic nervous system activity releases nitric oxide from the vascular endothelium, which binds to calcium, inactivates thrombin, and inhibits the generation and stabilization of insoluble fibrin. In the research literature, this is known as nitrergic neurogenic vasodilation. The capillary gate component explains why von Willebrand factor, factor 8, insoluble fibrin, D-dimer, or that is fibrin split products, blood viscosity, blood coagulability, blood pressure, cardiac output, heart rate, tissue perfusion, tissue oxygenation, atherosclerosis, and organ function all fluctuate in accord with autonomic balance. Its acute hyperactivation causes infarction, pulmonary embolus, thrombophlebitis, and high-altitude pulmonary edema, or HAPE. Its chronic hyperactivation accelerates atherosclerosis and capillary senescence, which causes diabetes, hypertension, eclampsia, and congestive heart failure, and increases the risk and severity of infarction, adult respiratory distress syndrome, and multi-organ failure syndrome. It's time for another break. The next slideshow will describe the capillary gate mechanism that regulates flow resistance in capillaries and the turbulence mechanism that regulates flow resistance in arteries and arterioles. Thanks for listening. Welcome to part 8 of this series of slideshows that describes the mammalian stress mechanism that was predicted by Hans Selye. This presentation will explain the capillary gate mechanism that is part of the capillary gate component. The turbulence mechanism will be explained in the following slideshow. This slideshow reviews the enzymatic interactions that generate and disintegrate insoluble fibrin in accord with autonomic balance. Sympathetic activity releases von Willebrand factor to generate insoluble fibrin, and parasympathetic activity releases nitric oxide to disintegrate insoluble fibrin into fibrin split products, or FSP. The diameter of capillaries is barely adequate to allow red cells to travel single file. Sympathetic nervous system activity extrudes von Willebrand factor from binding sites on the inner walls of capillaries. These von Willebrand factor binding sites are located next to binding sites for fibrinogen and fibronectin. Factor 8C in flowing blood binds to von Willebrand factor, which activates the 8C enzyme and generates insoluble fibrin strands on the inner walls of the capillary, shown in blue. This closes the capillary gate by slowing the passage of red cells through the capillary lumen. Parasympathetic nervous activity releases nitric oxide from capillary walls, which binds to calcium, inhibits thrombin activity, and accelerates the degeneration of insoluble fibrin into fibrin split products. This restores tissue perfusion, tissue oxygenation, organ function, and cardiac efficiency. The capillary gate mechanism is efficient and effective because capillary turbulence, flow, and pressure are negligible, and capillary surface area is vastly greater than all other vessels combined. The mechanism does not normally halt capillary flow or reduce perfusion to the point of causing ischemia or infarction, as evidenced by the absence of tissue ischemia and infarction in health and youth. But chronic hyperactivity of the mechanism accelerates the capillary deterioration that is part of the normal aging process. I call this accelerated capillary senility. The premature destruction of capillaries compromises tissue perfusion and oxygenation and predisposes to tissue ischemia, infarction, eclampsia, and organ dysfunction, and particularly congestive heart failure. Capillary hemostasis, which completely halts the passage of red cells through the capillary lumen, normally occurs only when tissue disruption directly exposes blood enzymes to tissue factor in extravascular tissues. Capillaries inexorably deteriorate and disappear as a natural consequence of the aging process, so that tissue perfusion is progressively compromised. Combinations of sedentary lifestyle, morbid obesity, emotional stress, trauma, surgery, and exposure to toxic chemicals and radiation can abnormally accelerate capillary senility. Accelerated capillary senility is the occult cause of type 2 diabetes, senile dementia, renal failure, essential hypertension, congestive heart failure, and eclampsia. Type 2 diabetes and essential hypertension seem totally unrelated, but they are the same disease. Though the severity of individual symptoms and manifestations are unique to individual patients, all are caused by accelerated capillary senility that simultaneously exaggerates capillary flow resistance and undermines glucose uptake by cells. The early stages of the disease are characterized by normal blood pressure at rest, exaggerated blood pressure in response to exercise or mental stress, small amounts of protein in the urine, and an impaired ability to process sugar. As the disease progresses, blood pressure remains abnormally high at rest, blood glucose levels become continuously elevated, and symptoms of progressive organ damage appear. The increased flow resistance exaggerates cardiac work. This does not cause the heart to become bigger and stronger. Instead, it induces fibroblast proliferation and collagen deposition in heart tissues that progressively undermines cardiac function, even though it causes heart walls to grow thicker. Eventually, this results in congestive heart failure. Exercise conditioning is the opposite of accelerated capillary senility. It induces capillary proliferation and muscle cell hypertrophy in the muscles and tissues affected by exercise. For example, running induces capillary proliferation in leg muscles, and weight training induces muscle cell hypertrophy in arms. The capillary proliferation reduces capillary flow resistance and enhances tissue perfusion and glucose uptake by cells. It enables tenfold increases in cardiac output during intense exercise, with little effect on blood pressure and negligible increases in cardiac size, weight, strength, and power. Exercise conditioning is thus beneficial in both diabetes and hypertension. In fact, it may be the most effective and least problematic treatment for these illnesses. Insulin and epinephrine are opposing hormones that extend autonomic effects to peripheral tissues that lack direct autonomic innervation. Sympathetic activity releases epinephrine from the adrenal glands. Epinephrine releases von Willebrand factor from the vascular endothelium, which closes the capillary gate. Epinephrine effects are most prominent in peripheral tissues, where direct sympathetic innervation is lacking, so that epinephrine enhances vital organ perfusion at the expense of peripheral tissues. Brain astrocytes produce TPA that preserves brain perfusion and prevents ischemic brain damage despite epinephrine dosage during cardiopulmonary resuscitation. In contrast, parasympathetic activity releases insulin from the pancreas, and insulin releases nitric oxide from the vascular endothelium, which binds to calcium, inhibits thrombin activity, opens the capillary gate, and enhances tissue perfusion and glucose uptake. The effect is most prominent in peripheral tissues where direct parasympathetic innervation is absent. Insulin is therapeutic because it prevents cell glucose starvation, but sulfonamide treatment is harmful because it aggravates cell glucose starvation. Understanding capillary gate operation and accelerated capillary senility confers an improved understanding of eclampsia. As mentioned in the previous slideshow, pregnancy exaggerates factor VIII activity, which closes the capillary gate and inhibits tissue perfusion. It also introduces the risk of meconium embolus, where large amounts of tissue factor enter the bloodstream and cause systemic factor VII activation. In most cases, accelerated capillary senility remains occult and overlooked in breeding age women, but pre-existing diabetes and hypertension exaggerate the risk of eclampsia during pregnancy. The occult accelerated capillary senility causes glucose intolerance and hypertension early in pregnancy, as the metabolic demands of pregnancy exaggerate perfusion requirements, while the stress of pregnancy closes the capillary gate, exaggerates flow resistance, and inhibits cardiac output, tissue perfusion, and glucose uptake. The onset of labor pain sharply exaggerates sympathetic tone and activity, closes the capillary gate, and causes the severe hypertension and glucose intolerance that characterize eclampsia. In addition, the stress of pregnancy accelerates capillary senility and exaggerates the incidence and severity of hypertension and diabetes in its aftermath. The next slideshow will discuss the turbulence mechanism, which explains why eclampsia is closely associated with DIC. It's time for another break. The next slideshow will explain the turbulence mechanism, which regulates turbulent blood viscosity in arteries and arterioles in accord with autonomic balance and complements the capillary gate mechanism. Welcome to part 9 of this series of slideshows that describe and discuss the mammalian stress mechanism that was predicted by Hans Selye. Recent advances in the understanding of turbulence provide revolutionary insights to the nature of mammalian physiology with implications that exceed the bounds of medicine. This presentation will discuss the nature of pipe flow turbulence and its relationship to vertebrate physiology. Turbulence was the greatest mystery of physics and engineering until it was recently discovered to have underlying order that can be described by mathematical equations. This led to the founding of a new branch of science known as chaos theory. Turbulent equations are called Mandelbrot equations, or fractals. The pictures above are examples of computer-generated fractals. There is similar underlying order in cloud formations, tree limbs, broccoli stalks, ferns, irregular coastlines, weather patterns, craggy mountain ranges, lung structure, heart rhythms, and pipe flow. Turbulent equations also explain how DNA efficiently stores anatomical shapes and forms that characterize complex animal and plant structures, as illustrated by the Barnsley's fern fractal equation on the right. In 2004, Belgian mechanical engineers used laser photography of water pipe flow to confirm mathematical predictions of turbulent pipe flow patterns. Turbulence appears in the form of bright red jet streams that move forward along the inner walls of the pipe. These force slower moving elements of the water toward the center of the pipe, where they move backward. As acceleration increases, the turbulent patterns temporarily persist and then suddenly transform to alternate turbulent patterns. This explains why turbulence induces pipe flow resistance and how it can dislodge rust from the inner surface of old pipes. At peak turbulent intensity, turbulence rings the inner surface of the vessel. Pulsatile blood flow operates at the threshold of peak turbulent intensity because this mobilizes particulate deposits from the inner surface of arteries and prevents atherosclerosis. The turbulence generates lateral forces that press on the inner wall of the vessel. These forces explain the palpable pulse and blood pressure measurement. Turbulent relationships are exponential, unstable, and powerful. Small changes can drastically alter turbulent patterns. This is called the butterfly effect, as when a butterfly flapping its wings in China causes a tornado in North America. Gun design illustrates the unpredictable interaction of turbulent variables. Gun design is a process of trial and error that achieves practical combinations of gunpowder chemistry and quantity, ambient temperature and humidity, cartridge size and shape, bullet size, shape and mass, barrel diameter and length, metal characteristics, and so forth. Altering any of these variables, and especially altering two or more variables simultaneously, may produce a gun that is unreliable, ineffective, or even dangerous to use. Pipe flow turbulence is affected by pipe length, diameter, curvature, bifurcation, imperfections, temperature, particulates, and the rate of acceleration. Turbulent lateral forces generated by pipe flow turbulence might be compared to the Bernoulli principle, where turbulent flow over the curved surface of an airplane wing generates powerful lifting forces that enable airplanes to fly. Such forces can explode or collapse pipes. Plumbers call this water hammer. Most plumbing systems in ordinary homes include a trapped column of air that cushions water hammer forces. Turbulence is the sole cause of pipe flow resistance, which is called viscosity. In medical literature, blood viscosity is customarily called systemic vascular resistance. Most common liquids, fluids, and gases such as air, carbon dioxide, water, milk, Kool-Aid, gasoline, oil, and so forth are called Newtonian fluids because they exhibit exponential increases in viscosity with increasing acceleration. Blood and cornstarch solutions are non-Newtonian fluids because they exhibit exponential decreases in viscosity with increasing acceleration. Non-Newtonian fluids are characterized by the presence of particulates that inhibit pipe flow turbulence. As blood accelerates, the unique shape and size of mammalian red blood cells causes them to spontaneously organize themselves into stacks that are called aggregate patterns in research literature. These red cell formations abolish turbulent flow patterns and eliminate flow resistance. Because of this, mammalian blood exhibits laminar flow during systole. Laminar flow enables extreme cardiac efficiency comparable to electrical superconductivity. Cardiac contractility is converted into pure kinetic energy with nearly 100% efficiency because turbulent flow resistance is absent. This explains how the mammalian heart can effortlessly increase its output by a factor of 10 during intense exercise, why athletic conditioning has minimal effect on heart size and weight, and why the exercise capacity of mammals is superior to that of reptiles. Hemoglobin encapsulation distinguishes vertebrates from invertebrates, and each class of vertebrates appears to be characterized by its own distinctive red cell morphology. This remains totally unexplained. Conventional theory assumes that the primary purpose of red cells is to deliver oxygen to peripheral tissues, but encapsulation does not improve the oxygen-carrying capacity of hemoglobin or tissue delivery of oxygen, and red cell mass is far greater than needed for effective oxygen transport. Red cell morphology alters vertebrate blood turbulence to facilitate environmental adaptation. Mammals evolved directly from reptiles, so they are closely related, but their red cells are dramatically different. Reptilian red cells are large, nucleated, and elliptical. Reptiles allow their body temperature to fluctuate with environmental temperatures, and their red cells exaggerate systolic blood turbulence to counteract atherosclerosis acceleration due to lipoprotein solidification at cool temperatures. This explains why reptiles have limited exercise tolerance and inferior cold tolerance. However, they require far less food than mammals. Mammals maintain their body temperature at the threshold of lipoprotein liquefaction so that lipoproteins blend with liquid blood elements and do not affect blood viscosity. This eliminates the problem of accelerated atherosclerosis caused by lipoprotein solidification at cool temperatures and enables them to employ small biconcave red cells that inhibit systolic blood turbulence and optimize cardiac efficiency and exercise tolerance. This enables mammals to thrive and function in cool temperatures, but it exaggerates food requirements and heat intolerance compared to reptiles. In mammals, anemia exaggerates blood turbulence, which impairs cardiac efficiency, undermines exercise tolerance, and exaggerates atherosclerosis resistance. Severe anemia, which most often occurs due to chronic renal failure, can paralyze hemostasis and mimic disseminated intravascular coagulation, but the cause is different. Hemostasis is restored with erythropoietin or transfusion with packed red blood cells to restore normal red cell mass. Excessive red cell mass, or polycythemia, inhibits blood turbulence, exaggerates blood coagulability, and accelerates atherosclerosis. Within limits, it enhances cardiac efficiency and exercise tolerance, which explains why athletes treat themselves with erythropoietin to enhance athletic performance, which is called blood doping. Polycythemia can also be caused by alcoholism, overenthusiastic erythropoietin treatment for anemia, and excessive transfusion with packed red blood cells. It increases the risk of DIC, and in severe cases can trigger DIC with devastating consequences. It's time for another break. The next slideshow will discuss the medical implications of mammalian blood turbulence. Thanks for listening. Welcome to part 10 of this series of slideshows that describes the mammalian stress mechanism that was predicted by Hans Selye. This presentation will explain the turbulence mechanism that regulates diastolic arterial turbulence in accord with autonomic balance. Mammalian physiology combines systolic laminar flow efficiency with diastolic turbulent cleansing to simultaneously optimize exercise capacity and atherosclerosis resistance. The heart effortlessly expels its contents in a fraction of a second as cardiac contractility is converted into pure, friction-free kinetic energy. As blood velocity declines during diastole, red cell aggregate formations suddenly disintegrate. This instantaneously converts the kinetic energy of flowing blood into a turbulent pulse wave that propagates towards the periphery. This traveling turbulent wave halts blood movement, mobilizes particulate deposits from the inner walls of arteries to prevent atherosclerosis, and generates lateral forces that enable blood pressure measurement and the palpable pulse. This graph illustrates the dynamic relationships between blood flow velocity and aortic blood turbulence in a dog. The cardiac cycle begins with a period of isovolemic contraction where pressure within the ventricle rises above a threshold that causes the aortic valve to open, whereupon systolic ejection accelerates blood velocity from 0 to 125 centimeters per second, and blood surges throughout the arterial tree until the heart expels its contents. This happens in less than a tenth of a second. During the following tenth of a second, turbulent flow resistance appears as the velocity of speeding blood declines and the red cell aggregate formations deteriorate. As velocity declines below a critical threshold, the aggregate formations disintegrate, and the kinetic energy of the speeding blood instantaneously converts into a burst of turbulent energy that halts the forward flow of blood as it travels towards the periphery. In this particular example, where the measurements were obtained in the aorta, there is a brief reversal in the direction of blood flow. This occurs when the cardiac muscle relaxes and the cartilage skeleton of the heart causes the ventricle to expand and draw the aortic valve shut. Systole is thus complete within 0.2 of a second. The brief flow reversal initiates a pulsatile wave of turbulence that propagates rapidly throughout the arterial tree, halting arterial blood flow as it moves. The efficiency and brevity of systolic blood propulsion has been persistently overlooked. The weak forward force that propels blood cannot be measured with conventional equipment, and arterial turbulence appears only during diastole after the ventricle is at rest. Diastolic arterial turbulence is analogous to pipe flow turbulence. The turbulent pattern is potentially affected by temperature, cardiac contractility, arterial length and diameter, red cell mass, bifurcations, and imperfections. But mammalian physiology normally maintains all these parameters within narrow ranges. Cardiac contractility varies little from beat to beat, so that each heartbeat produces a brief burst of intense turbulence that mobilizes debris from the inner walls of arteries and optimizes atherosclerosis resistance. The turbulence mechanism generates and disintegrates insoluble fibrin in accord with autonomic balance in the same manner as the capillary gate mechanism that was described in previous slideshows, but its effects occur in flowing blood rather than on the inner walls of capillaries. It releases von Willebrand factor from the vascular endothelium in accord with sympathetic tone and activity to activate factor VII and generate insoluble fibrin. It releases nitric oxide from the vascular endothelium in accord with parasympathetic nervous system tone and activity to disintegrate insoluble fibrin. It regulates the equilibrium of fibrinogen, soluble fibrin, and insoluble fibrin in flowing blood. The turbulence mechanism regulates insoluble fibrin in flowing blood, where it entangles red cells, disrupts red cell aggregates, induces systolic turbulent friction, and reduces end-systolic velocity. This alters diastolic blood turbulence so as to exaggerate blood viscosity and coagulability, and undermine cardiac efficiency, decrease cardiac output, elevate blood pressure, increase pulse rate, and accelerate atherosclerosis. By exaggerating blood viscosity, the turbulence mechanism reduces peak systolic velocity, which alters diastolic turbulence in favor of increased lateral forces at the expense of turbulent mixing. The increased viscosity also reduces ejection fraction, causing a compensatory increase in heart rate via the Starling mechanism. These relationships explain why sympathetic activity causes tachycardia, hypertension, and decreased tissue perfusion. Blood pressure is a misleading guide to therapeutic intervention because the relationship between blood pressure, tissue perfusion, and cardiac performance is unreliable. Pulsatile turbulence varies in accord with arterial diameter, curvature, and bifurcations, so that its intensity varies from location to location. Blood pressure cuff width and patient anatomy perturb blood pressure measurement. Invasive arterial cannula transducers must be calibrated in accord with cuff pressure. Regardless of how it is measured, blood pressure is only indirectly related to cardiac contractility, cardiac output, tissue perfusion, and tissue oxygenation. Multiple variables affect the turbulent forces, including temperature, red cell mass, and blood viscosity, as well as cardiac contractility. Brain-damaged, bedridden patients often survive for years without developing atherosclerosis, but inadequate blood turbulence exaggerates blood coagulability and accelerates atherosclerosis, while excessive blood turbulence undermines hemostasis and inhibits atherosclerosis. Inadequate turbulence enables particulate deposits that incite an inflammatory process that produces atherosclerosis. Blood cholesterol is incorporated into the atheroma, but does not cause it. Atherosclerosis typically appears on the greater curvatures and bifurcations of large proximal arteries where turbulence is exponentially decreased. Decreasing distal aortic or arterial diameter exponentially exaggerates turbulence and inhibits atherosclerosis. Chronic stresses due to smoking, fear, and apprehension, chronic illnesses, chemical exposure, trauma, and surgery activate the turbulence mechanism and accelerate atherosclerosis. Down syndrome mitigates fear that activates the turbulence mechanism. Anemia exaggerates blood turbulence, inhibits atherosclerosis, and undermines hemostasis. Polycythemia inhibits blood turbulence, accelerates atherosclerosis, and exaggerates blood coagulability. Hemophilia, von Willebrand disease, and anticoagulant medications inhibit insoluble fibrin, enhance turbulence, retard atherosclerosis, and paralyze hemostasis. Extreme reductions in blood turbulence can exaggerate blood coagulability and trigger systemic coagulation activity that is called disseminated intravascular coagulation, or DIC. Such activity rapidly consumes coagulation substances and paralyzes hemostasis. This usually involves multiple factors: excessive elevations of red cell mass due to transfusion with washed, packed red cells, polycythemia vera, and erythropoietin treatment all increase the risk of DIC. The release of tissue factor into systemic circulation by head injuries, severe trauma, amniotic fluid embolus, and extensive surgery can cause DIC. Turbulence mechanism hyperactivity due to hypothermia, pain, fear, and other stresses can aggravate the problem. Regardless of how it starts, systemic coagulation activity rapidly depletes fibrinogen and fibronectin as it generates excessive quantities of soluble fibrin and defective forms of insoluble fibrin. The soluble fibrin forms deposits on the inner walls of arteries, disrupts placental function, and binds to defective red cell clots to form rosette bodies that characterize the phenomenon. If the defective coagulation process reduces red cell mass below a critical threshold, excessive turbulence paralyzes hemostasis in the manner of anemia. Treatment should include control of pain, stress, and hypothermia, as well as restoration of red cell mass and coagulation precursors. This concludes the basic introduction of Selye's mechanism. If you have suffered through all the previous presentations, you must be immune to stress, and you will probably live another 200 years. I hope that these slideshows will inspire you to read my published papers, which can be obtained via my website, www.stressmechanism.com. As time permits, I plan to add additional slideshows that will explain anesthesia history, the new theory of anesthesia, analgesia and allostasis, and the unified theory of biology that is enabled by Selye's mechanism. I am also preparing a book that summarizes the implications of stress theory. Thanks for listening.